good evening, everybody. Here we are again tonight with Conversations with a Doc, and Dr. Kelly Mills is going to be speaking on deep brain stimulation. So we're very lucky to have him and very glad that he agreed to speak. And I've got some of your questions, but remember, if you have other questions, feel free to put them in the chat. And I hope that you will fill out the evaluation that we will be sending at the end of all of this. It is really very important. So thank you very much. And Dr. Mills, it's all yours.
Okay, thank you, Judy, for inviting me. Let me just see. So you should see my full screen now.
Yeah.
Okay. Okay, well, I was asked to speak about who makes a good candidate for deep brain stimulation. I'm a neurologist and I work at Johns Hopkins. I see patients with all different types of movement disorders, but a big focus for me is running our neuromodulation and advanced therapies clinic. And so this is where we evaluate people with known diagnoses like essential tremor, Parkinson's disease, dystonia, and others for the use of deep brain stimulation and other more surgical therapies. So I'm not going to talk for too long tonight. I'm going to try and open it up for discussion and questions since it's supposed to be a conversation. But I'll give a little bit of background on what deep brain stimulation targets, how we do assessments and what we assess to collect information and learn about patients. And then also a little about, at the broader level, what DBS does in some trials, because I think that helps to factor into this discussion about would or would not it help you at the individual level. So as far as target symptoms, so who's helped by advanced therapies? And when I say advanced therapies, that includes DBS and some other things that I'm not going to get into tonight. But if we start with Parkinson's disease, if there's someone with Parkinson's disease and they have some of the main movement symptoms, slow movement, stiffness, and tremor, and these do or have responded to medications like dopamine replacement in the past, but either the medicine wears off and we have what we call motor fluctuations, or the medications cause side effects that limit their use. So maybe these motor symptoms of slow movement, stiffness, or tremor would go away if the person could take higher medication doses, but they're unable to because of side effects that come out as they escalate the dose. So if either of these cases are occurring, then we say someone should be referred for advanced therapies. And I'm not going to focus on other diseases tonight, but essential tremor and dystonia also, if medications aren't controlling the movement symptoms, they can be referred for advanced therapies. So I want to focus in a little bit on this and talk about what I mean here and expand on which symptoms are good target symptoms. So I said slow movement, stiffness, and tremor. And I said motor fluctuation. So what is a motor fluctuation? So I use this graph to describe this. Across the bottom are hours of the day, 6 a.m. going all the way up to 6 a.m. Each of these black arrows is the time at which a hypothetical patient takes a dose of dopamine replacement. Let's say it's carbidopa levodopa. And going up this way is the amount of levodopa in their blood. If you could sample their blood continuously, you would see that they take a dose and the level goes up, and then it comes down. And then as the next dose is kicking in, the level goes up again and comes down. And then as the next dose is kicking in, up, down, up, down, up, down. Now, in early disease, so often within the first 3-5 years, sometimes less, sometimes more, whether this dose in the blood is at the peak or at the trough, it's enough to allow the brain to produce its dopamine and to stave off the movement symptoms of Parkinson's, the stiffness, slowness, and tremor. And so once the person starts taking their doses for the day, they're really not noticing any reemergence of those movement symptoms. With advancing disease, the thresholds change. So now you have someone, let's say, who's had Parkinson's for 11 years. And I just made up that number, but let's just say longer. And the threshold for the symptom time has come up such that you have to be on a higher dose to clear that blue bar and to get into the green zone. And then the other thing that's happening is at the peak of these doses, you see you get into the red zone, and this is where you might get side effects. In this case, it's dyskinesia, which is involuntary extra wiggly movement. It could be lightheadedness from blood pressure dropping when the peak is high. It could be nausea. And so this person, this hypothetical person, they start off the day in the blue zone, so they're slow, stiff, and they have tremor. They take their medication dose, it goes up, it peaks, and they're getting side effects. And then it's coming back through this green window where they're feeling pretty good, but it's only maybe an hour of good time without dyskinesia. And then they hit this trough. And now what you see is the trough's down in the blue zone. So when the dose is hitting its nadir, you're getting the symptoms coming out. They're getting more shuffling gait, they're stiffening up, it's harder to get up from a seat, harder to get out of a car, they can't use their hands as well to type or eat, more tremors coming out. They take their next dose, it kicks in, and now they go up to the peak phase again where they're having dyskinesia. And then it wears off again and they have off time. So they on, off, all day. And we call this phenomenon motor fluctuations. And this is important to understand because deep brain stimulation doesn't really do that much better than the best on time. It can give you on time without as much dyskinesia, but it really brings up the off times. So it brings this trough up so that you're not hitting these low lows as much. And you can eliminate them if done, in someone who's looking like this all day, you should be able to eliminate a substantial amount of this off time, we call it, which are these troughs. So if someone, doesn't understand this concept, I want you to ask me about it later when we go to questions, because I think this is key to understanding how not just DBS helps, but a lot of the medications that are used in adjunct with carbidopa, levodopa, and dopamine replacement. So what about other symptoms that are target symptoms? There are also some refractory symptoms, and these are things that maybe even at this peak effect, maybe stiffness improves, maybe the patient can move faster, but sometimes the tremor is persistent. Even at a high dose of dopamine replacement or medications, they may have persistent tremor. It's often rest tremor. It could be a kinetic tremor, which is a tremor that comes out when you're using the hand, whereas a rest tremor is a tremor that's just sitting there when you're not using the hand. Another motor symptom that sometimes becomes refractory to dopamine replacement, like levodopa, is dystonia. And by refractory, I mean it just doesn't respond. It doesn't improve. So dystonia can be a cramping or a pulling of muscles. In Parkinson's, it often happens in a foot or a hand. The toes may curl under the foot or the ankle may curl in. Sometimes it can happen in the neck, and we call that cervical dystonia. This is something else that deep brain stimulation can help. Some other symptoms that are tougher and where I think we really have to think about whether or not deep brain stimulation is going to target it are freezing of gait and postural instability. So what is freezing of gait? So freezing of gait, I'm going to show you an example here. Turn my laser pointer off. Okay, so I'm going to scoot along. So the video is behaving badly. So actually, I'm going to reverse that because I can't fast forward it. So put freezing of gait on the back burner for a second. What is postural instability? Postural instability is the medical term for when people with Parkinson's develop a tendency to fall. If they trip the littlest bit or their center of gravity gets knocked off balance, they can't correct themselves and they just go down like a log. And so, if you're seeing a movement disorder specialist, they're probably always, having you stand up and pulling you back and trying to make you fall. And it's probably your favorite part of the whole visit. But there's a reason for that, because we want to know if there's postural instability. So you're going to see testing here where this person, the doctor pulls her back right here, and normally you'd put your foot back or try and catch yourself, and she just falls back like a log. And so she's lost her postural response. And that is something that causes a lot of falls in Parkinson's. That specific problem with stance and balance does not typically improve with Parkinson's, with deep brain stimulation. Now, if there's slowness involved and the feet just aren't moving fast enough to get them out far enough, then sometimes that can be improved. If levodopa improves it, then DBS could improve it. But we usually say that balance is something that is not really going to improve with deep brain stimulation. So if your main problem is balance, with easy trips and falls, and you go down and you can't catch yourself, then you really have to have a discussion with the neurologist about whether or not that's a good target symptom for Parkinson's. Another thing that's tricky is freezing of gait. So here's an example of freezing of gait. So this man is approaching this threshold, this door, and it triggers a freezing episode. So his feet are frozen. He can't take a step. Here you'll see it really gets into a freeze here where he just can't initiate that big step to get through. And with the turn, it makes it almost worse. It's kind of frozen. There's a lot of freezing. Now, once you give this person levodopa, the freezing goes away. So freezing is a tricky symptom to target with deep brain stimulation. If the medication, and you see even on levodopa, he has tremor, so he has a refractory tremor. So even on medication, when it's in his system, there's not much freezing. So we typically see that type of freezing, especially if it improves during turning, as something that can respond to deep brain stimulation. If dopamine replacement improves the freezing, and if the problem is just that the dopamine is wearing off all the time, then DBS can help freezing. But in many patients, the freezing persists even when the levodopa is in their system. So even when they're fully medicated, they still have a lot of freezing. And we call that on freezing, because you're freezing even on medications. And unfortunately, that type of freezing really doesn't respond as well to deep brain stimulation, in my experience and in studies. So this is where, when someone says, would DBS help me, it really takes a long discussion with the neurologist as part of an evaluation to figure out what are the target motor symptoms, how are they treated or not treated by medications, and what's the relationship between medications and each of these motor symptoms, and then how do you rank those motor systems for you as far as how disabling they are. So if someone has medication refractory freezing of gait, they're on time, they're even freezing, and that's their main problem, but they also have tremor, DBS will take away the tremor, but will it take away the on freezing? Probably not. And so this is where an individualized answer is really important, and it takes, a thorough evaluation to do this. So how do we do this? How do we figure all this out? Well, we spend a lot of time assessing patients. And so I'm going to give you an example of how we operate at our center, but I can tell you, and knowing everybody else in the region, all the other movement disorders physicians, this is very similar in the other programs around. So assessments that impact DBS recommendations. So we really start our assessments often at the time of referral. This could be from another movement disorders neurologist or from a general neurologist into the advanced therapies pipeline. We give quarterly educational seminars. It's usually me giving the talk, but we may have people come to that online Zoom seminar to learn about this even before they're able to be seen in the clinic. We can mail them information if requested. The initial consultation is usually with a neurologist to go through everything that we're talking about now. We may do medicine on-off testing, and I'm going to tell you more about that. Neuropsychological evaluation to look at mental strengths and weaknesses. Sometimes we have a psychiatric evaluation, and then we also do social support and caregiver support evaluation. We take all of these pieces of data back together and have a monthly conference. In fact, ours is tomorrow night, where everybody from the team who's evaluated the patient gets together and talks about it. Then we take that assessment and those recommendations back to the patient, educate them on our thinking, and then make a decision with them about what the best next step is. So the first thing I mentioned there on this list of types of assessments we do is on-off testing. So remember, I just got finished telling you that whether or not something responds to medications impacts the decision as about whether or not it's a good target symptom for deep brain stimulation. So how do we figure out what this is? Well, we ask people. So the first thing is we take a history. Does your tremor go away when your medication kicks in? Does your slowness of movement improve when your medication kicks in? Can you get out of the car easier? Can you walk faster? Does your hand dexterity improve? And patients are often able to tell you that. But we also get an objective measure of on-off testing. So actually, to see this, and sometimes patients aren't sure which things improve, which aren't, we bring people in after an overnight medication washout. We usually start at very early in the morning at 8 a.m. so that they're not going their whole day not having had any medications. They can just sleep, wake up in the morning, come in first thing. We assess them, doing all the tests that your neurologist probably does with you, like finger tapping, moving your hands, walking. And then we give them their pills in clinic. We wait, 45 minutes, an hour, and then we reassess them when they're feeling medicated, when they're in the best state. And this tells us which symptoms respond to levodopa and which don't, because that, feeding back to that graph I showed you about motor fluctuations, tells us which movement symptoms might improve with DBS or other advanced therapies and which won't. So this is very important in understanding the likelihood that someone's going to feel better and perform better with deep brain stimulation. The other thing we do is neuropsychological evaluation. And so this is just an example of some of our colleagues in neuropsychology who work with Parkinson's patients to do this type of testing. So this is cognitive testing. It's really to look at strengths and weaknesses of thinking. Most people have strengths and weaknesses, and Parkinson's can cause some problems in certain areas. It's not the type of test where there's a pass-fail. It's really just looking at what is the pattern of cognitive performance across different types of thinking: memory, language, attention, problem solving, visual perception. And this factors into decision making as well. So I'm going to tell you why. So this usually is a couple hours because there's a lot of tests to go through. And the friendly neuropsychologists also spend a lot of time just interviewing you and talking to you about your daily function. We want to do this during your best on period when you're feeling as well as possible. So why do we do this? Well, this is actually an area of my research specifically because I have a lot of patients that get deep brain stimulation. There have been reports of people who have cognitive decline after DBS surgery. And so there was a study done where people were randomized to either get deep brain stimulation or just continue on medical therapy for 6 months of follow-up. And what they found was that there was a multi-domain cognitive decline, meaning across more than one type of thinking, like memory, attention, visual-spatial function, language, in 3% of the people who continue to get meds. So, that portion is basically attributable to the progression of Parkinson's over time. But there was 11% of people who got DBS. And so then, we as a field had to drill down and figure out, well, who are the people who are at risk for having decline in their cognitive function from going through surgery, right? Because we want to be able to identify those people and talk with them about that risk. Certainly what we don't want to do is make your tremor better, your slowness better, your stiffness better, but make your thinking worse. We don't want that trade-off. So that's why we do the neuropsychological evaluation. We look at patterns across all of these different types of thinking. And there have been certain patterns of thinking that are higher risk, that are associated with a higher risk of cognitive decline. Now, most people with Parkinson's have some cognitive issues. It's often a problem with attention, some difficulties with multitasking, solving problems a little bit slower than they used to. They still come to the right answer, but maybe it takes a little longer, or finding the right word when you're speaking. Just because you have something like that doesn't mean that it's dangerous to have deep brain stimulation. But what we do want to see is if an individual has a pattern of cognitive impairments that have been shown to be concerning for a decline from DBS surgery. So potentially we could avoid it. I mean, there are other therapies, there are other options, and maybe that means we go with an alternative to try and avoid that. That's why we do the neuropsychological evaluation. So what are risk factors for cognitive decline and people being worked up?
So the biggest risk factor is really adverse events. So if there's if there's some bruising of the brain, some edema, if there's some bleeding, if there's an infection, if there's any type of adverse event that happens from the surgery, although these are rare, that's probably the biggest factor for predicting any cognitive changes from the surgery itself. Baseline individual tests also can be predictive, and that's why we do a lot of these in our neuropsychological testing. That's why we're doing the cognitive testing. It's not just to torture you. So we know that if people's performance are very low in some of these tests, especially if they're low in all of them, that they're probably going to be at higher risk. And then we're going to want to say, hey, there's potential to benefit from this surgery, but we're really concerned about the risk, and maybe it's not a great idea. Interestingly, the things that did not predict cognitive decline were disease duration, severity of the disease, mood symptoms, or education levels. So just because you've had Parkinson's longer doesn't necessarily put you at a higher risk for having cognitive changes from the surgery itself. That's why we really have to hone into what is at the individual patient level, what is their cognitive performance. And again, I'm explaining this to help people understand why we get the neuropsychological evaluation. Sometimes we do a psychiatric evaluation. Many people with Parkinson's disease struggle with symptoms like depression, anxiety, hallucinations, and so obsessive or compulsive behavior. And those can also be factors in DBS. If those are present, it doesn't mean that DBS won't help you. It just means that it might change how we do DBS. It might change when we do DBS. Like if you're in the depth of a very deep depression, maybe we should get that tuned up first and get that better treated before we jump to putting you through a brain surgery. And sometimes it even impacts like the brain target that we approach. So when we do DBS surgery, we can choose 3 different places where we put the electrodes in the brain. And sometimes some of these other non-movement symptoms aid in that target selection. So the presence or absence of these may influence therapy options. So what do we do with all these assessments and evaluations? We have a meeting. Neurologists, neurosurgeons, neuropsychologists, psychiatrists, if the patient was seen by a psychiatrist, Parkinson's nurses, and we discuss many different things. Is DBS needed? Is do-OPA needed? Are there good target symptoms? Is it safe in this individual? If DBS, what brain target are we going to do? If DBS, which side? Because we can treat one side of the body or both sides. And so we kind of discuss this, and then we circle back after there's consensus in our group to share our recommendations and our thinking with the patient and educate them on, why we're making these recommendations in kind of a shared decision-making model. So I want to talk a little bit about the evidence for benefit, because that's another thing that factors into who's a good candidate. So there's a couple different devices that are indicated. At our center, we use all 3 just based on the individual case. But if we look back to what DBS actually does based on the clinical trials, these are some of the earliest clinical trials. You can see that this is 1998, meaning the DBS had already been done for 6 or 8 years to collect all the data for this study. So this was starting in the early 90s in Europe, and this comes from a famous French group that really pioneered a lot of the DBS work. For those of you who hate graphs, I'm sorry, I really like them. What we have here is different time points: before surgery, 1 month after surgery, 3 months after surgery, 6 months, and 12 months. Going up the side here is the severity of Parkinson's. It's a scale that we use to measure the movement symptoms like tremor, slowness, and stiffness. The white bars are off medicine. So this is what the average score is when people come in off medicine. You can see it's very high because they have severe symptoms. On medication, it's much lower. It's over 50% better. And so these people before surgery, off medicine, they look very bad. On medication, they were doing much better. And now what do you see after surgery? You don't really see much change in the on medicine score, right? The black bar is still about the same. There's a little bit of a difference. It declines a little bit. Tremor's probably a little bit better. That even didn't go away with medicine. But the big difference is the off medicine score. And that's getting back to that idea of motor fluctuations. It's really not treating the peak effect. It's really bringing up those troughs of each dose. So now when someone's medicines wear down, they're going from black to white bar here or here or here, not going from this all the way up to this. So people tend not to notice the wearing off of medications as much after DBS surgery. That's the main outcome. When you look at another way of measuring this, we look at a scale of activities of daily living. So you give people a questionnaire on how much does Parkinson's affect your ability to get dressed, to do your hygiene, to prepare food, things like that. Those are called the activities of daily living. And we see the same trend. Off medicine, it's much harder for people to do these things that they need to do to be independent. On medicine, they're easier, and there's a big difference. After DBS, you see this white bar come down pretty substantially. So even when the medicines are off, they're not functioning as poorly as they were before surgery. What does it help when you zoom out and say, okay, this is great if you measure this in the little rating scales that you scientists like to do, but how does this affect my quality of life, right? So that's where we really need to look at quality of life. If you give people a quality of life index, asking, questions about your mobility in the community, like how often do you not go do something because you can't get out and move around? How's your emotional well-being? How concerned about the stigma of your disease are you? How do you feel your social support is? These are the types of things here that this scale is measuring. And so we can see the greenish gray bars, this is the change from baseline. So basically, if the bar is going up, it means there's improvement after DBS. And these little pale gray bars are with staying on medication. The patients were randomized to either stay on medication or get DBS. And you can see there's really no change. There's a little bit of worsening in some of these things like activities, daily living, cognition, communication, and most of the domains improve. So I think in answering the question about who makes a good candidate for DBS, the other thing that people always ask about is like, what is the window for DBS? And so I've talked about when that window opens. The window opens when you have symptoms that are not adequately treated by medications. You have wearing off, you have the motor fluctuations, or your doses are limited because you're getting too much dyskinesia, or you're having side effects and you still have movement symptoms that are not adequately treated. And you and your neurologist decide, look, we've tried a bunch of different medications, we've tried tweaking the doses, but we're not getting anywhere, so we need to consider advanced therapies. Now, the studies that I've shown you that enrolled people in this state, they were typically studying people who've had Parkinson's for a long time. So in the large United States trial that was done and published back in 2009, people in that study, on average, had Parkinson's for 13 years. The biggest German trial that was also used to justify use of DBS in Europe, again, average of 13 years for people entering that study. So unfortunately, by that point, many people are disabled from important aspects of their life. Maybe because of the unpredictability and the wearing off of the medicines, they've pulled back from work, they pulled back from social activities, maybe they've pulled back from going to rock steady boxing as frequently because they might wear off suddenly when they're there. So a question comes up, should it be done earlier? Right when we start to see these fluctuations happening, should we be intervening earlier before someone really has to pull back from life because of that problem? And so a trial set out to answer this called the early STIM trial. And it was published way back in 2013, over a decade ago now. And they randomized people who were earlier in the course, who were having motor fluctuations, but their average disease duration was only 7 years. And they were allowed to enroll if they had at least had Parkinson's for only 4 years. And so here you can see the red line is, so this is the scale of quality of life. And the blue line is people who continued on their oral medications. The red line is people who got DBS, and you can see there was an improvement, and then that improvement was sustained. The curves stayed apart for the duration of the 2-year study. And you can see down here that it improved most domains of quality of life. So there's been a tendency in the field to not, it kind of was originally described as, well, when the person's really at their wits' end and they really don't want to go on and everything's falling apart in their life, then you do something like deep brain stimulation because it's more invasive. But I think there's been a movement in the field to at least consider it, or at least to have the conversation about it earlier before people are really experiencing that level of disability. And so I think with that, I'll just say the other things that kind of, so that's the beginning of the window. The close of the window is really when you have symptoms that DBS won't help, and those symptoms are the majority of your problem. So if you think of a pie chart of your disability with Parkinson's disease, if 75% of that pie chart is from cognitive impairment and 25% of that pie chart is from balance problems and falls, is DBS going to help you at that point? It's not going to address either of those things. If your tremor and your motor fluctuations and your stiffness and slowness are only a little sliver of that, then DBS isn't going to have as big of an effect on you. So if you're going to do it, you want to do it before the things that DBS does not help take over as some of the biggest problems. Like, it's not going to help hallucinations. It's not going to help dementia. It's not going to help falls. At least in many cases, it won't help falls. So with that, I'm going to, I think, turn this into a discussion.
Okay, would you like me to start asking the questions now?
Sure.
So the first question is about what is the cost of the procedure and does Medicare cover it?
Definitely Medicare covers it. Definitely for Parkinson's disease. There are some experimental conditions that, we're still trying to get Medicare to cover for, but for Parkinson's disease, essential tremor, and most cases of dystonia, it's covered. How much it costs really depends on if you have straight Medicare, if you have Medicare Advantage, if you have a supplemental, but it's going to be like any hospitalization. So the deep brain stimulation device implantation is a hospitalization. You go in for a surgery, it's an elective surgery, you get it prior authorized, or if it's Medicare, it doesn't require prior auth, but you have to make sure you have a condition that it covers it for, which Parkinson's it does. And then whatever your normal copay would be on a hospital, like if you get a knee done or if you get a hip done, whatever your normal copay is going to be on that based on your mix of Medicare and supplementals or anything else, that's what you would be responsible for. It's not a long hospitalization. Usually you get the surgery. Usually you stay that night and then maybe one more night, depending on how you're doing. If you're great the next day and you really want to get out of there and you're walking and talking and feeling excellent, then the surgeon may let you go home the next day, but usually it's 2 nights of observation. But yeah, the actual cost depends so much on the specific hospital, how much they bill and how much your insurance, that it's hard for me to give a great estimate on that.
So here's a question from the chat. How soon can you start Botox for ET?
After DBS, or does that just have nothing to do with DBS?
Well, I'm not sure which question was first here, but when do you use Botox versus DBS?
For essential tremor?
I guess, yeah.
Well, Botox, for its tremor, it really depends on what muscles are involved for the tremor. So if the neurologist thinks that your type of tremor might be improved by Botox, I usually would try that because Botox is reversible and it's short-term effect. So you get Botox. If it works and you're happy, great. You have to get it every 3 or 4 months because it only lasts a couple months at a time. If it doesn't work, okay, it washes out of your system and you move on to the next thing. If that next thing is DBS, then you can do that. But DBS is more of a permanent solution, whereas Botox is still a medication and its effect wears off. So, and it's also much less invasive. The needles, I have patients who've been injected with Botox for 30 years, and they keep coming back because they like the effect, mostly more dystonia than tremor. But I have some tremor patients too.
And if needles aren't your thing, then it could be a problem for you. But they're pretty small needles, and it's very low risk compared to more permanent invasive procedures.
Is DBS reversible if results are negative?
So yes and no. The nice thing about DBS is that it can be turned down or it can be turned off. So let's say you have a tremor in your hand and I turn it up until the tremor goes away. Well, let's say once you get home, you realize that I've caused some side effect in that hand, that even though the tremor goes away, the hand's curling up or doing something funny, then the system can be turned down. And patients even have the option to turn it down at home or turn it off at home. Now, if they don't want that, they're hesitant to do anything that changes their brain function, then they don't have to, but they even have that option of doing some home programming. So it can be reversed in that it's like the volume on your TV. You can turn it up, you can turn it down. We can change many of the parameters, and that's nice because if you're not getting response, you come back and we do more programming and tweak the settings on it until we find good control of your symptoms. Now, the device, as far as its reversibility, it's implanted in your brain. So to be completely reversible, it can be just turned off and left in, but to be completely reversible, it would take another surgery to take it out safely, because you'd have to incise the skin and pull it out.
I have ataxia as well. Does that make any difference?
Yes, definitely. That would impact. If you have Parkinson's disease and ataxia, then you'd have to take a close look at which symptoms you are targeting with DBS, and are those due to Parkinson's disease. Ataxia, for the type of DBS that we can do now, that insurance covers and that's like well accepted as effective therapy, we don't necessarily target ataxia. There are some research studies out there looking at DBS of different parts of the cerebellum and other brain areas to treat ataxia, but that's not something that's standard of care now.
What percentage of patients does DBS not help?
Yeah, I'm trying to answer that so I think there's not a good percentage for how many it doesn't help. I think it's more about what percentage of help does it provide. So the way that we measure this is like you have a rating scale, like I was showing you those bar graphs, right? The degree of improvement, if we give you a score of your severity of Parkinson's before surgery, and then we repeat that score after surgery, we can calculate the percent improvement. And so on average, depending on the population, if you do it on a younger population who's earlier in the disease course, we can see a 70 to 80% improvement in the severity of their Parkinson's. If we do it on a more severely affected population, we're looking at more at a 30 to 50% improvement in the severity. Whether or not that is considered to be working by an individual patient is very subjective to the patient. So you could have a 30% improvement in the severity, in the objective severity of your Parkinson's, but if it's targeting the one thing that you really worried about, which let's say it was tremor or stiffness in your right arm, that could completely change your quality of life. So I think if you do good candidate selection and there aren't any complications, then you can have some response in everybody. It's really the degree of response that differs by what are the target symptoms and how well is it programmed by the neurologist, how well are the leads put in the right place by the surgeon. But it's usually kind of a degree of improvement that we talk about rather than like a percentage of people that just don't respond at all. Because theoretically, if you don't respond at all, you probably don't have Parkinson's, or the leads are in the wrong place in your brain.
How exactly does DBS work? What is the mechanism that causes the improvement in symptoms?
Well, that was the slide I stopped on. So now you're going to get more slides.
There's one person
Um,
who really would like that, at least. All right, let me get rid of this. Okay.
so the simple way I think of describing it is think of a cardiac pacemaker. You may know people or you may have a cardiac pacemaker. The reason people have pacemakers is there's an arrhythmia in the heart. This means that the electrical signal that goes through the heart and makes it beat is moving in the wrong direction or isn't functioning properly. The electrical signal is not going through the right network in the heart. And so if you put in a pacemaker, it delivers stimulation to compensate for that and to improve the electrical activity of the heart. In research dating back into the 1960s, really moving into the 70s and then 80s, people found out first in monkeys and then in humans, the network in the brain that underlies a lot of the movement symptoms. So this is a schematic, and it's not an electrical grid, it's actually different areas of the brain where, Parkinson's disease causes a lack of dopamine going into this part. And these downstream parts of this network, like a computer network, are affected by that. And it was shown in animal models first and then in humans that if you apply electrical stimulation downstream to one of these nodes, like the subthalamic nucleus or the globus pallidus internus, that's the STN or the GPI, that you can normalize the electrical activity flowing through this network and you can normalize brain function even in the absence of dopamine. So it basically does the same thing to this network that dopamine does, but even in the absence. And that's why it works for off times. When the brain's not getting dopamine, it kind of does the same thing to this network. I hope that's in depth enough. I could go further because we researched this at our center, but it might get a little technical.
All right, can I stop taking medications after DBS?
It depends on the type of DBS. So the brain target that we use most often is the subthalamic nucleus, and it usually allows, on average, a 50% reduction in the levodopa dose, sometimes more, sometimes less. I've had some patients, I had one patient recently who went down by 75%. But the goal really should be not to stop taking medications. The goal really should be to be better than you were before surgery. And often that takes a combination of medications and DBF together to make you better than you were before surgery. I have had some patients where they feel so great with their DBS activated, they want to stop medications altogether. And then they go from doing really well to doing better, but not as well as they could be if they were on some medications in combination with DBS. But it usually allows a medication reduction that's substantial.
What improvements are in the pipeline for DBS?
So right now, you get the system implanted. You come into the office of the neurologist, and we look at the symptoms you have. We tune the DBS system using like a tablet that communicates with it to put in settings, and then we reevaluate your symptoms. Then we make more changes, then we reevaluate your symptoms. And so it's this back and forth. The initial programming that I do usually takes 2 hours, and then people have to come back in the office for multiple visits. And they're usually happy to do so because they're improving each time. But each time we're trying to build on that and tweak it further to get, the maximum coverage of their motor symptoms. The next generation of devices will, so some of the research we're doing at our center is to have the device record brain signals, pick out patterns in those brain signals that represent the symptoms like stiffness, slowness, and tremor, and then have the device be able to adjust itself to target those brain symptoms. And we call that a closed loop system, because then you don't have to come back for as many visits. And the other thing about it is that, like, let's say you're doing really well that day and the brain signals are saying, hey, the Parkinson symptoms aren't as bad today. Well, then maybe it can kind of tone down the stimulation. And at other times when the brain signals are worse, it can ramp it back up. And so it can adapt even in real time to what's going on in your brain and that network activity that's underlying the movement symptoms.
Let's see here. I've heard of virtual or remote programming of DBS devices. Can you explain what that means?
One of the device manufacturers has a system where on the programmer, like clinicians like myself have a programmer that's basically a tablet, and the patients have a programmer that's usually like a smartphone. That over the internet, over an internet connection, the doctor can connect to the patient and make and adjust their stimulator theoretically anywhere in the world, wherever you have a data connection. That can be useful, especially for people who live very remotely. The vast preference across most people is still to have a lot of the main programming done in person, because we're looking at your gait, your walking, we're testing your, when you come in to see the neurologist and they move your arm, they say relax and they move your arm, they're testing for rigidity. That's not something you can do through a screen. And looking for side effects and assessing the clinical effect is it's easier to do in person. So for the initial turn on after surgery and some of the major programming visits, we usually try to do that in person. The remote programming I find is helpful for like little tweaks, like, okay, well, I can see a tremor through the video, so let's see if we turn this up, if it helps. But there are a lot of people that don't have tremor, and it's harder to see their movement symptoms through video. You have to feel them or examine them. And so it can be helpful, and it can give access to people who live really far away from a center that does DBS. And so it's a nice advancement. They kind of came out with that during COVID, which was really helpful, to be able to facilitate more visits than people were comfortable with at the time too.
I don't know if you can answer this one. This is probably for the person's physician. Are my severe balance issues from ataxia or Parkinson's? I fall several times a week.
Yeah, I'm gonna have to agree with Judy on that one. I mean, that takes a physical examination to look for signs of ataxic gait or Parkinsonian gait, and then to try and parse out, okay, what percentage of this is Parkinson's, what percentage is ataxia, is going to be based on the physical examination, doing the exam maneuvers that the neurologist does with you in the office.
Can I use DBS for, spasticity or only Botox?
CVS isn't that helpful. DBS isn't that helpful for spasticity. I shouldn't say that. Rigidity is a type of stiffness that comes with Parkinson's, and DBS is very helpful for that. Spasticity is something that usually comes from other types of conditions like strokes, multiple sclerosis, brain injury. That can cause spasticity, cerebral palsy. And deep brain stimulation is not targeting the brain area that controls spasticity. But if by saying spasticity, if you mean rigidity, which is the type of stiffness that happens in Parkinson's disease, it can be very helpful for that and for dystonia.
How long do the benefits of DBS last?
So for the things it treats, tremor, stiffness, and slowness, it'll last forever.
Oh, okay.
But that's not all Parkinson's is, right? So I have patients who have had DBS for over 20 years, 25 years, and their balance may have gotten so bad that they're using a rollator full time or maybe even in a wheelchair. And so they come in using their rollator or maybe a wheelchair. If I turn off their DBS, their tremors come right back out and their arms stiffen up and their legs stiffen up and their rigidity comes back and their hands slow down. So for the things it treats, tremor, stiffness, and slowness, it treats them long-term, as long as you keep changing the battery. But Parkinson's causes other things that DBS doesn't treat.
Does DBS work immediately?
It can work once it's turned on. So after the surgery, usually we let the brain heal. So when you poke the brain with these wires, it can cause some edema, and that swelling can actually give a clinical benefit and can cover up tremor. It can cover up stiffness. It can make the person feel better. If we turn on the device and try and target the symptoms when they're gone from the swelling, then we have nothing to target with the programming. We don't know what settings to put in it. So we usually wait 3 or 4 weeks until the brain is fully healed, and then bring you back in and then turn it on. In Parkinson's disease, yes, you should walk out of the first programming session with the neurologist once it's turned on feeling better. It's probably not going to be the final settings you're on. It might take a couple more visits to tweak it a little bit further, but you should feel a substantial benefit.
Where is the battery located? What size is it? And how long does it remain charged?
Okay, am I still sharing my screen? Do you see my screen?
I see you.
Okay.
I don't see any. There we go.
Okay, I have a lot of slides here that are not. So this is a schematic. This is, if you had x-ray vision and you could see through this person's skin, this is what you would see. And it's actually, this is an older one, so they're smaller than this now. But there's a battery that is the same displacement as a pacemaker. So it's actually modeled after and built by the same companies that make pacemakers. But instead of the lead, the wire going into your heart, it goes under the skin, under the neck skin, behind the ear, under the scalp, and over the top of the head. And then it goes through a small hole in the brain and goes deep into the brain. That's why it's called deep brain stimulation. The battery is in the chest, just under the clavicle. They're getting smaller and smaller, and actually now they're mostly rechargeable. And so that lets the battery get very small, because the ones that we use that are non-rechargeable, they have to hold, enough charge for 4 or 5 years. The rechargeable can be very small because you just charge it every couple of weeks.
And how often would you advise reprogramming the DBS system?
Completely depends on the symptoms. I have some patients with Parkinson's who, we do 3, maybe 4 programming visits after their surgery, and they're fine for a long time. But then with the progression of the disease, they come back in and say, I used to only have tremor on the right hand, and you program DBS to target that, but now I'm getting tremor on the left hand, and that's the underlying progression of the disease. And so then we have to do more programming for that target. So, like a lot of things with Parkinson's, it sometimes can feel like whack-a-mole, but the good news is that you can reprogram it if new things come up. But once you've been through enough settings to kind of optimize it, and the neurologist says, like, this is what we're going to get at this time, then you don't have to keep getting dramatic changes made unless a new thing comes up.
How does deep brain stimulation compare to other surgical possibilities?
Well, that's a whole talk. But I would say that, so the other main two are focused ultrasound for medication refractory tremor. And that really focuses on tremor. So people where the tremor is the top problem for them, not the slowness that happens when the medicine wears off, not the stiffness that happens when the medicine wears off. But it's really just tremor. Focused ultrasound can be an option there. It's less invasive in that you don't have to have a system put in you. You don't have to have, actually, let me see if I think. So here, to answer this, so you don't have a hole drilled to put in the wire, you don't have any hardware, there's no battery charging, fewer trips to the doctors, and minimal infection risk. On the downside, it's a permanent lesion. You use this intense focused ultrasound to burn a hole in the brain, and that's a permanent hole that stays there. And that's what gives you the effect. It's in the same place where you would put an electrode if you were putting a DBS electrode in for tremor. The downside is that there's no changing over time, so that if the tremor gets worse, you can't just turn it up like you would DBS or change the settings like you would DBS. It's kind of like one time and you're done. Like you get, like I try and tell my son, you get what you get, you don't get upset. He's gonna be happy that I quoted him because he started saying that now. But it's permanent, and some of the side effects can also be permanent. If you get a side effect, you can't just turn it down like you can DBS. The field still doesn't know what to do if the tremor comes back. Do you repeat the ultrasonication and make the lesion bigger in the brain? And usually you have to separate the treatments, where if you have tremor in both hands, you're going to treat one side of the brain. And then the FDA approval is that you can treat the other side of the brain, but you have to wait 9 months between the two ultrasound treatments. The other main thing that is surgical that we compare to is duopa. So this is where, instead of having the levodopa go up and down with each pill, you just put in a pump that infuses it at a constant rate. And so you can keep their levodopa levels right in that sweet spot all day. It involves putting a tube through the stomach down into the part of the intestine called the jejunum. The reason that's done is the jejunum is the exact spot where levodopa is absorbed. So you're dripping it in to just the right spot in the GI system. So it doesn't have to go through the stomach. It doesn't interact as much with food. And this is what it looks like. So you have a pump, you have a cartridge of levodopa gel, and the pump is infusing it through this little tube that goes right through the stomach wall. The difference there is that it's still levodopa. So if you're limited by bad side effects like dyskinesia, blood pressure dropping, which we call orthostatic hypotension, hallucinations, which are sometimes worse with dyskinesia, then you're still getting the same medication. It's not like you're able to reduce the levodopa. It's just coming in a different form.
Okay, so what is Parkinson's psychosis? There are 3 questions here. What is Parkinson's psychosis? How frequent are hallucinations in Parkinson's? And are PD hallucinations different than those experienced by schizophrenics?
Parkinson's disease psychosis typically includes hallucinations and or delusions. Hallucinations can be visual, auditory, tactile, which is feeling, like you feel something on you, or olfactory, which is smell. In Parkinson's disease, by far and away, the visual hallucinations are the most common, but people can report other hallucinations like tactile hallucinations. The other side of that, I said hallucinations and delusions. Delusions are fixed false beliefs. So you may, if you have a delusion, you may believe something that's just objectively not true. So unfortunately, a common delusion may be delusions of infidelity. So someone just all of a sudden gets this bug in their head, this belief that their spouse, who might be their primary caregiver and is bending over backward to help them, is in the next room, cheating on them with someone else. Or I've had people think that their spouse is in the next room, like, doing hard drugs or something. So they're false beliefs that are disconnected from reality. Those can also happen, unfortunately. The difference from other causes of psychosis, the presentation is different in that in schizophrenia, the hallucinations are much more likely to be auditory than visual. So it's usually more voices that people hear. Visual hallucinations are less likely. There can be delusions, but they usually have a different content in schizophrenia. Often it can be like, beliefs of magical, like the TV is talking to someone or sending cryptic messages, or there's, inert devices have magical powers or things like that. So the content is a little bit different in many cases as well. I think it was like a 3-part question. Did I answer all 3 parts? I don't remember.
What is Parkinson's psychosis? How frequent are hallucinations in Parkinson's? And are PD hallucinations different than those experienced by schizophrenics?
So Parkinson's delusion or Parkinson's psychosis with hallucinations, it depends on how long you are having Parkinson's disease. If you have Parkinson's disease for 20 years or 30 years, it increases the chances significantly that you're going to have some hallucinations. So it really is a factor of disease duration, similar to, cognitive impairment. Hallucinations often can come around the same time as more severe cognitive impairment like dementia.
I think that's all the questions. The last comment, oh, this was nice. Thank you very much, Dr. Mills and Judy. This is so helpful and I appreciate you both very much. Well, thank you to whoever said that.
Glad it helped someone.
Yeah. And thank you everybody for tuning in, and hopefully we'll see you next time. And Dr. Mills, thank you.
And thanks, Judy, for all you do for the community.
Thanks.
All right,
Night.
take
Good
it.
night,
Bye-bye.
everybody.
Good night.
Fill out the evaluations. Thank you.